I'm going to be discussing a paper that I have co-authored this year that was published in Retina with my co-author, Dr. Chris Gergis, your guidance consultant. So VKH is a multi-system inflammatory disorder with a special predilection for melanocyte-containing tissues. All right. We know that the choroid, the inner ear, the brain, and the skin are very melanocytic-driven or heavy tissues, which are the main targets of VKH. It starts in the eye with a prodromal stage of 3 to 5 days of fever, meningitis or encephalitis, headache, tinnitus, and dizziness. This is usually followed by the uveitic stage with multifocal choroiditis of exudative detachment, followed by a chronic convalescent stage with vitiligo, poliosis, the Shakura sign, and the depigmented fundus, as well as a recurrent stage, which is the stage of complications such as cataract, glaucoma, and iris nodules. So since we know that this is probably a choroidal disease, insight into choroidal culpability in VKH has always been dependent on ICG, which is not available in our country, unfortunately. ICG has detected leaking choroidal vessels, indicating an inflammatory choroidal vasculopathy. However, oddly enough, it has also detected areas of hypofluorescence, which means that there is a delay in choriocapillaris perfusion, or basically hypoperfusion, which is not something that we don't really equate with an inflammation. So the pitfalls of ICG is that there is a lack of information on the structural changes in OCT, there is a lack of quantitative data, unavailability of ICG in many areas such as our country, risk of dye-based complications as well. So OCT has changed the way we look at VKH. OCT typically shows subretinal fluid, which usually gives you this multilobulated appearance, and definitely the very thick choroid is one of the main areas, the main things that we see on OCT. So basically, here's the question: is the choroid thickened, as we can see on OCT, or is it hypoperfused, as we see on ICG? So this question can be answered using OCTA angiography, which could give you a segmental, superficial deep capillary plexus, as well as a choriocapillaris plexus, so you can identify the vascularity on each individual layer. So there is two ways of doing a quantitative analysis of choriocapillaris flow using OCTA angiography. There's the machine built-in analysis. However, by the company's own accords, this is not the best way of doing it. It's not very helpful in removing the artifacts and detecting the actually true pixels. And so image analysis software is the way to do it. This is how most literature is driven these days. So this brings us to the purpose of our study. We wanted to quantitatively analyze the vascular changes in the choriocapillaris with eyes with VKH during both activity and remission, using an entity called a parafoveal adjusted flow index on OCTA angiography. We're going to talk about this later. We wanted to correlate these with structural changes, and we used two areas to determine these structural changes: the choriocapillaris flow density maps and the choroidal thickness during both stages. So we defined active VKH according to the most recent Sun classification. This is the early stage diagnosis and the late stage diagnosis. For the sake of time, I'm not going to go through them. The structural markers that I just identified: the 3-point choroidal thickness using enhanced depth imaging OCT. So basically you identify 3 points, which are 300 microns on either side of the fovea, and you get the average of them in order to ensure uniformity of your measurements. The other way is looking at the choriocapillaris density map, and remember, whenever you have less active areas or hyperperfused areas, you get greens and blues. If you have more capillary perfusion, you get higher pitched colors such as orange, yellow, and red. AFI, where it's done on both 3x3 and 6x6 millimeter scans. Again, this is a quick way of telling you how AFI is done. So basically, after you image the patient, you get the full retinal thickness map, because this is how we're going to identify the pixel noise. So you get the mean pixels in the foveal vascular zone. Everything in the foveal vascular zone is not actual flow, because we know that this is a vascular, so anything that is white here is noise. So this is how we're going to get the threshold for this individual picture. And then we do a centration of 1/3 ETDRS circles on the center of the choriocapillaris slab. This is in order to ensure uniformity in all eyes, because patients could be off-center when you image them. And then we remove the noise. So basically, you only leave everything that is above the threshold. Everything is below should be removed. Only pixels above the noise represents to flow. And this is a walkthrough how patients were managed with VKH. They were started on oral prednisolone and tapered over weeks. And then we started pushing immunosuppressives, that was patient-tailored according to the patient's medical records, as well as patient tolerance. Imaging was done immediately after subfoveal fluid regression in order to avoid artifacts from the overlying fluid, and then after clinical remission. Clinical remission was identified as the presence of AC cells with HSAs of 0.5 and choroidal thickness less than 400. So here's a walkthrough of the results. We started off with 39 eyes of 25 patients. Unfortunately, 12 of these eyes were excluded, leaving a final of 23 eyes of 14 patients. This is a walkthrough of why these patients were excluded. Some of them developed media opacities later on, some of them developed subretinal fibrosis, and others developed CNVs. And the mean follow-up period was about 8.7 months in order to achieve complete clinical remission. This is a graph highlighting the changes that we saw both in adjusted flow index and in choroidal thickness. So the two at the top are adjusted flow index. This is the 3x3 scans, and these are the 6x6 scans. Orange is in remission, so this is after the patient became inactive. Blue is during activity. As you can see that there was higher flow during remission rather than during activity. This was reciprocally seen in the mean choroidal thickness. There was higher thickness of the choroid, the mean 3-point choroidal thickness during activity rather than during remission. So this was actually pretty surprising because we walked through the numbers, the less choroidal thickness during activity and the higher flow during remission. So in the structural changes, this is an example of a patient where you can appreciate these. This is a multicolor picture of both eyes of a patient with active VKH. This scan shows you the thickened choroid during activity and then how it's thinned during remission. The choriocapillaris density map shows you what we were talking about: less flow, more green and more blue, so there is less perfusion during activity, and then more red and green and orange during remission, so there is more flow. And the same was seen in the left eye, again, less thickness and more flow. So this is an example of how we calculate these numbers. It gives you a number. During activity, this particular patient had a number adjusted flow index of 0.45, and then this increased to 0.53 during remission. So basically, in a nutshell, during activity, there was higher choroidal thickness and less choroidal flow. During remission, there was the opposite: more flow and less thickness. So this was very surprising, to be honest, because we used to think of choroidal thickness as a surrogate of choroidal flow, right? Because everyone that wanted to determine choroidal thickness on OCT, we used to think that a thick choroid means that there is more flow. So is this actually true? We just have to go back to basics just to remember why this is not really true. The choroid is one of the most vascular tissues in the body. We know that it starts with a feeding arteriole that breaks down into capillaries and then drains through a venule. And this is the way we look at it. We know it's a very vascular structure. However, electron microscopic structure on the choriocapillaris shows you that there are multiple spaces in between these capillaries. These spaces constitute the choroidal stroma. The stroma includes fibroblasts, collagenous tissues, elastic tissues, and most importantly for us right now, immunological and hematological cells. So there is another entity other than flow. If we look at electron microscopic evidence of VKH, we know that there is a granulomatous inflammation. These granulomatous inflammations include a lot of immunological cells into the stroma. So in simple maths, if there is a choroidal volume, which includes the vessels and the stroma, the volume it can be expressed in choroidal thickness, the vessels can be expressed in the flow. The stroma is going to be influenced by the inflammatory cells that happen during activity. So basically what we think happens is that during activity there is more cells, which means that there is more thickness. However, the stroma now becomes very thickened, so it compresses the lobules and there is less flow. During remission, the opposite happens. The cells go away, so the thickness goes down. However, the flow increases because now the lobules are not compressed. So basically, this answers the question that we started: is the choroid thickened or is it hyperperfused? It's both. It's thickened because there are more cells, so the stroma is thick. However, there is less flow because there is compression of the choriocapillaris. This goes hand in hand with many findings in literature which was able to identify choroidal granulomas on the atlas seen here. So this gives you an impression that there is definitely another entity other than blood. There is a stromal tissue that becomes thickened with inflammatory cells. The limitations of our study include a relatively small sample size, a relatively short follow-up, and lack of analysis of blood flow in the large choroidal vessels because we use a spectral domain imaging machine, so it's not going to be able to give you a good enough picture of the larger choroidal vessels. The strengths of our study included a prospective longitudinal study of about 9-month follow-up, stringent inclusion criteria. There was both qualitative and quantitative choriocapillaris flow analysis, and we correlated with structural choroidal thickness in enhanced depth imaging. In conclusion, OCT angiography provides both in vivo and quantitative blood flow metrics. Active VKH shows you thicker choroids, that there is less flow compared to remission. There is dense granulomatous stromal infiltration, which may dampen the choriocapillaris flow because the stroma is thickened and so the blood vessels are compressed. Larger studies are needed to evaluating using choriocapillaris flow as a tool for monitoring and predicting disease activity in the future. And thank you very much for your attention.
Congratulations على فكرة برضك for the publication of this the very prestigious journal.
Thank you.
And I think you should repeat that with a swept source.
Definitely, yeah. So we wanted to look at the large choroidal vessels to see if the changes are replicated. However, the spectral domain machine doesn't give you good enough pictures, and so if we attempted to get pictures using the spectral domain, the pixel intensity, the numbers that you're going to get are not going to be real. We need a swept source machine that is good enough to give you a very clear, crisp picture of the large choroidal vessels, so you're able to analyze the pixels with clarity.
Okay. Yeah. Thank you.
All right. Thank you very much. هو اسمه ايمج جي هو سوفت وير عملته ال NIH بس هو موجود افيلبل يعني. All right, so this